Welcome to this special talk on complement physiology and tubular epithelial cells, central paradigms in diabetic kidney disease. I'm Dr. Ashutosh Mishra, consultant Diabeto and endocrinologist at Panacea Hospital, Varanasi. Today, we'll explore how two once underestimated players, the complement system and tubular epithelial cells, have emerged as central agents driving diabetic kidney disease, or DKD. This shift in understanding could redefine how we diagnose and treat diabetic renal injury in the future. For decades, DKD was viewed mainly as a glomerular disease. The breakdown of the filtration barrier, microalbuminuria, and podocyte loss were considered the defining features. But recent insights from cellular and molecular research have broadened that picture. The focus has shifted downstream toward the kidney tubules and the innate immune system's complement cascade. We now know that tubular epithelial cells aren't passive victims but active sensors and amplifiers of injury in diabetes. Hyperglycemia, oxidative stress, and complement activation create a damaging loop that drives inflammation, fibrosis, and ultimately nephron loss. The complement system, a network of more than 30 plasma and membrane-bound proteins, was designed as a first-line immune defense. It identifies pathogens, clears immune complexes, and triggers inflammation when needed. There are three activation routes. 1. The classical pathway, triggered by antigen-antibody complexes. 2. The lectin pathway, responding to altered carbohydrates. 3. The alternative pathway, providing continuous immune surveillance. All three converge on C3 convertase, leading to C3 and C5 cleavage and finally the formation of the membrane attack complex, or MAC. In diabetes, sustained hyperglycemia and advanced glycation end products distort complement regulation. Key inhibitors like factor H and CD59 lose function, allowing uncontrolled activation, transforming a protective system into a chronic source of tissue injury. Every day, the human kidney filters over 180 liters of plasma, demanding extraordinary metabolic resilience from tubular epithelial cells, especially those in the proximal tubule. But under diabetes, these cells are assaulted from all sides: high glucose, albumin overload, oxidative stress, and inflammatory cytokines. Albumin endocytosis itself activates NF-kappa B and induces profibrotic mediators like TGF-beta and MCP1. Modern data reveal that tubular cells synthesize their own complement components, express pattern recognition receptors, and engage in immune dialogue with macrophages and endothelial cells. Thus, the tubule emerges as both a sensor of metabolic stress and a driver of renal inflammation. Chronic hyperglycemia sets off a molecular chain reaction: AGE accumulation, PKC activation, and mitochondrial overload, all of which prime complement activation. Filtered complement fragments, such as C3a and C5a, bombard the tubular surface, stimulating local cytokine programs. Sublytic MAC deposition, even without full cell lysis, causes calcium influx, mitochondrial dysfunction, and slow, irreversible injury. This repeated insult leads to persistent NF-kappa B activation and widespread inflammation, establishing a vicious cycle where complement amplifies metabolic stress, and damaged tubules further amplify complement activation. As stress accumulates, tubular epithelial cells face an existential crisis. Initially, adaptive mechanisms like autophagy and metabolic rerouting keep them alive. But over time, mitochondrial exhaustion leads to three principal fates. 1. Apoptosis, a silent programmed death driven by oxidative stress. 2. Ferroptosis, an iron-dependent, lipid peroxidation-driven death noted in diabetic tubules with reduced GPX4 activity. 3. Pyroptosis, a fiery inflammatory cell death mediated by the NLRP3 inflammasome and caspase-1 activation. When these injuries accumulate, tubular cells enter senescence, a state of metabolic arrest where they secrete inflammatory and fibrotic mediators collectively known as SASP, perpetuating local injury and interstitial scarring. Over months to years, these micro-injuries culminate in tubulo-interstitial fibrosis marked by deposition of collagens, fibronectin, and laminin, replacing functional tubular architecture. Key signaling cascades, including TGF-beta/SMAD and WNT/beta-catenin, drive fibroblast activation and epithelial to mesenchymal transition. Clinical pathology consistently shows that tubulo-interstitial fibrosis, not glomerular injury, correlates most closely with long-term renal decline. The good news is that this deeper understanding is changing how we diagnose and treat DKD. Urinary assays for complement fragments, C3A, C5A, SMAC, and tubular markers like KIM1 and NGAL can detect subclinical injury far earlier than albuminuria. Therapeutically, emerging drugs aim to block complement overactivation such as C5A receptor antagonists and C3 inhibitors, while others target senescence, ferroptosis, or mitochondrial dysfunction. Existing agents like SGLT2 inhibitors, finerenone, and GLP-1 receptor agonists already confer renal protection, partly through reducing oxidative stress, tubular load, and inflammation. In essence, modern nephrology is rewriting the DKD narrative. The glomerulus remains important, but the true battleground lies in the tubule complement axis. Hyperglycemia primes the attack, complement amplifies it, and tubular cells, once thought passive, fight, adapt, and finally surrender to fibrosis. Future kidney protection will rest upon intercepting this crosstalk through drugs, biomarkers, and personalized monitoring to preserve nephron health before the decline becomes irreversible. Thank you for listening. This has been Dr. Ashutosh Mishra, sharing insights into the evolving pathophysiology of diabetic kidney disease and the promise of complement-targeted therapy in the years ahead.